Now I'll compile this comprehensive research into a detailed report on how the legal non-recognition of personality disorders affects society. How the legal non-recognition of personality disorders affects us all. The limited or inconsistent legal recognition of personality disorders creates a cascade of consequences that extend far beyond individual cases, affecting criminal justice outcomes, public safety, healthcare access, family law proceedings, workplace rights, and broader societal costs. Despite affecting approximately 9 to 10% of the adult population, personality disorders occupy a contested space in legal frameworks, often excluded from mental health protections, while simultaneously invoked to justify indefinite detention or used to undermine credibility in legal proceedings. 1.1. The insanity defense gap. The legal system has systematically narrowed mental health defenses to exclude most personality disorders, creating a significant accountability gap. Following the 1981 assassination attempt on President Reagan by John Hinckley, public backlash led to dramatic reforms that specifically targeted personality disorders. The American Law Institute's Model Penal Code now explicitly excludes an abnormality manifested only by repeated criminal or otherwise antisocial conduct from qualifying as a mental disease or defect. 4 states have eliminated the insanity defense entirely: Kansas, Idaho, Montana, and Utah, while others like Oregon and Oklahoma have specifically barred personality disorders, particularly antisocial personality disorder (ASPD), from insanity defense protections. In Fucha versus Louisiana, the Supreme Court accepted expert testimony that ASPD was not a mental illness sufficient to justify continued detention after an insanity acquittal. This creates a fundamental inequity. Individuals with personality disorders that demonstrably impair cognitive functioning, impulse control, and decision-making capacity are held to the same legal standards as neurotypical individuals. Research shows that borderline personality disorder, BPD, for instance, involves frontal limbic abnormalities, dissociative states, and impaired volitional control, yet these neurobiological factors are often dismissed in courtrooms. 1.2. The sexual predator exception, using personality disorders to detain indefinitely. In a striking contradiction, personality disorders that cannot justify exculpation for criminal acts can justify indefinite civil commitment after sentences are served. Following the Supreme Court decisions in Kansas v. Hendricks, 1997, and Kansas v. Crane, 2002, states enacted sexually violent predator (SDP) laws that define dangerousness partly through mental abnormality or personality disorder. Washington State's SVP law, among the nation's first, allows indefinite commitment to the McNeil Island Special Commitment Center for individuals who have a mental abnormality or personality disorder, making them likely to engage in predatory acts of sexual violence. As of 2017, 230 offenders were held under this system. These laws essentially use the mental health system for public safety purposes, what the American Psychiatric Association's Task Force on Sexually Dangerous Offenders called a serious assault on the integrity of psychiatry. The legal logic is internally inconsistent. Personality disorders are simultaneously not mental illness enough to mitigate criminal responsibility, yet mental illness enough to justify preventive detention without temporal limit. 1.3. Overrepresentation in correctional populations. The exclusion of personality disorders from meaningful legal recognition contributes to mass incarceration of individuals who might benefit more from treatment than punishment. Research reveals staggering prevalence rates. Borderline personality disorder. Community prevalence is 1 to 2%, but 12 to 30% among inmates, with some studies finding rates as high as 45% when using clinical screening tools. Antisocial personality disorder. 50 to 80% of incarcerated offenders meet diagnostic criteria. Overall mental illness. 44% of jail inmates and 37% of prison inmates have a mental illness, compared to 18% in the general population. These individuals face longer incarceration periods, more disciplinary sanctions, and higher rates of recidivism than those without behavioral health issues. The legal system's failure to recognize personality disorders as legitimate mental health conditions means that correctional facilities have become de facto mental health institutions, a role they are ill-equipped to fulfill. Civil commitment laws generally require both a mental disorder and dangerousness to self or others. However, the legal status of personality disorders in this context varies significantly by jurisdiction. Some states have explicitly questioned whether personality disorders constitute mental illness sufficient for civil commitment purposes, creating uncertainty about whether individuals in crisis can access emergency mental health interventions. In Washington state, for example, civil commitment requires clear and convincing evidence of a mental disorder causing danger or inability to care for basic needs. The ambiguous status of personality disorders means that individuals experiencing acute crises, such as dissociative episodes in BPD or severe paranoid states in other personality disorders, may not meet commitment criteria, even when genuinely at risk. This creates a tragic gap. Individuals too mentally disordered to function safely in the community may be deemed not disordered enough for involuntary treatment, yet too impaired to seek voluntary care effectively. 3.1. The double-edged sword of diagnosis. In custody disputes, personality disorder diagnoses function as powerful weapons that can both illuminate genuine parenting concerns and serve as tools for unfair discrimination. Courts are instructed to consider parental mental health as it affects the child's best interests. But the stigma surrounding personality disorders, particularly narcissistic personality disorder, NPD, borderline personality disorder, BPD, and antisocial personality disorder, often leads to presumptive unfitness rather than individualized assessment. Research and legal practice reveal that courts often view personality disorder diagnoses as disqualifying factors rather than conditions requiring accommodation. The diagnosis can be weaponized by one parent against another, with courts sometimes accepting testimony about personality disorders without requiring formal psychiatric evaluation. Family courts lack trauma literacy and frequently cannot distinguish between active symptoms and recovered or well-managed conditions. Mothers with BPD, in particular, face accusations of manipulation and weaponization of the legal system, which may lead to loss of custody even when they are primary caregivers. A diagnosis alone should not determine custody outcomes, yet the legal system's limited understanding of personality disorders often results in binary thinking. Diagnosed parent equals unfit parent. 3.2. Impact on children and families. The failure to properly recognize and address personality disorders in family law creates ripple effects. Children may be placed with genuinely dangerous parents when courts cannot distinguish personality pathology from normal parenting stress. Children may be unnecessarily separated from parents who have recovered or whose conditions are well managed. False allegations based on personality disorder can destroy parent-child relationships. The stigma prevents parents from seeking treatment, fearing it will be used against them in custody proceedings. 4.1. Complex coverage under the Americans with Disabilities Act. The Americans with Disabilities Act, ADA, potentially covers personality disorders, but only if they constitute an impairment that substantially limits one or more major life activities. The EEOC's psychiatric enforcement guidance explicitly states that not all conditions listed in the DSM qualify as disabilities, and personality disorders face particular scrutiny. This creates several problems. Employer discrimination. Studies show individuals with mental health conditions, including personality disorders, face significant workplace discrimination, including fear of disclosure, lower job quality, increased work loss days, and reluctance to request accommodations. Burden of proof. Employees must prove their specific personality disorder substantially limits major life activities, a challenging standard when the disorder primarily affects interpersonal relationships or emotional regulation. Employment litigation complexities. Courts increasingly allow employers to argue that an employee's personality disorder, rather than workplace discrimination, caused workplace conflicts. In employment litigation, personality disorders are sometimes used to blame employees for their own victimization, rather than recognizing legitimate discrimination. Research on borderline personality disorder symptoms among 3,672 workers found correlations with increased work loss days, lower job quality, reduced decision latitude and coworker support, and impaired decision-making abilities. Yet, legal protections remain inconsistent. 4.2. Stigma as a barrier to workplace integration. The workplace stigma surrounding personality disorders significantly hinders professional careers. Individuals often face discrimination in hiring and promotion practices, leading to economic consequences and social isolation. Fear of disclosure creates a vicious cycle. Employees hide their conditions to avoid discrimination, but hiding prevents them from accessing necessary accommodations, which leads to poor performance and potential termination. 5.1. Systemic barriers to care. Despite personality disorders imposing substantial economic burdens, comparable to schizophrenia, and exceeding depression and anxiety disorders, individuals with these conditions face extraordinary barriers to healthcare access. Affordability barriers. Individuals with severe psychological distress, which include many with personality disorders, report significantly higher rates of worry about affording medical bills. 68.3% versus 38.9% in the general population, and normal healthcare costs, 61.3% versus 21.7%. Availability barriers. Those with severe psychological distress face higher rates of inability to get appointments soon enough, 19.9% versus 5.4%. Excessive wait times, 13.8% versus 3.5%, and transportation difficulties, 12.0% versus 1.1%. Stigma in healthcare settings. Healthcare professionals often hold stigmatizing attitudes toward personality disorders, particularly BPD, viewing patients as difficult, attention-seeking, or manipulative. This stigma creates significant barriers to accessing physical healthcare, as medical professionals may view physical problems through the lens of the personality disorder, rather than investigating legitimate health concerns. 5.2. Limited treatment access. Despite evidence of efficacy, early intervention for personality disorders, particularly BPD, has demonstrated effectiveness, with 9 published randomized controlled trials showing that structured psychological interventions can be delivered using widely available clinical skills rather than requiring lengthy specialized therapy. Yet these interventions remain largely unavailable due to systemic factors. Insurance coverage for effective BPD treatments is limited. Long wait lists for specialized care, lack of trained clinicians in mainstream mental health services, stigma preventing young people from seeking help early when intervention is most effective. The treatment gap for mental and substance use disorders is higher than for any other health sector, and personality disorders face additional stigma-related barriers beyond general mental health conditions. 6.1. Direct and indirect economic costs. The economic burden of personality disorders is substantial, yet the legal system's failure to recognize them as serious mental health conditions means resources are misallocated toward punishment rather than treatment. Individual costs. Treatment-seeking patients with personality disorders averaged €11,126, approximately $12,000 to $13,000 in total annual costs, with 66.5% representing direct medical costs and 33.5% representing productivity losses. BPD and obsessive-compulsive personality disorder showed the highest cost associations. Societal costs. The economic burden substantially exceeds that of depression or generalized anxiety disorder and is comparable to schizophrenia. When including comorbid conditions, which are common, costs increase further. Mood disorders, substance use disorders, and eating disorders independently contribute to health service costs among those with personality disorders. Incarceration costs. With 12 to 45% of inmates having BPD alone and 50 to 80% meeting criteria for ASPD, correctional systems bear enormous costs for populations that might be better served through mental health interventions. Washington State, for example, paid over $80 million in fines for failing to provide timely competency restoration services. costs that might have been reduced through earlier mental health intervention. Global burden. Mental disorders overall, including personality disorders, constituted 10.4% of the global burden of disease in 2010 and represented approximately $5 trillion in economic costs globally. The economic losses from untreated mental illness deplete labor supply and capital, worsening both individual poverty and national economic output. 6.2. Costs of non-treatment. The legal system's failure to recognize personality disorders means that individuals cycle through expensive crisis interventions rather than receiving cost-effective early treatment. Emergency department visits and crisis hospitalizations, repeated incarcerations, lost productivity and workforce participation, intergenerational transmission of trauma and dysfunction, victim costs from violence and abuse. Research suggests that a 90-day mental health treatment might prevent the 10-year imprisonment of an individual with mental illness, a cost-benefit ratio the legal system largely ignores. 7.1. The punishment versus treatment debate. The legal system's default toward punishment rather than treatment for individuals with personality disorders creates several public safety concerns. Higher recidivism. Without addressing underlying mental health issues, individuals cycle in and out of the criminal justice system. Evidence-based treatment of mental illness and substance misuse contributes to public safety by decreasing reoffending rates and provides economic benefits. Deterioration during incarceration. Prison environments often exacerbate symptoms of personality disorders, particularly BPD, leading to increased self-harm, suicide attempts, and institutional misconduct. Nearly 1 in 4 inmates with BPD engage in institutional violence or self-harm that could be reduced through appropriate treatment. Community reintegration failures. Upon release, individuals with untreated personality disorders face barriers to successful reentry, including lack of healthcare, job skills, stable housing, and poor connections with community mental health providers. These factors increase relapse and rearrest probability. 7.2. Secondary victimization. The legal system's handling of personality disorders can create secondary trauma for victims. Polyvictims. Individuals with personality disorders who are also crime victims experience heightened vulnerability to secondary victimization by the criminal justice system. Their credibility may be questioned due to their diagnosis, their rights may be minimized, and they may experience increased trauma symptoms from legal proceedings. Intimate partner violence victims. When perpetrators have personality disorders that go unrecognized and untreated, the cycle of violence continues. Conversely, when victims have personality disorder diagnoses, their reports of abuse may be dismissed as manifestations of their mental illness. Family members and children. Children of parents with untreated personality disorders experience ongoing harm when legal systems fail to properly assess, treat, and monitor these cases. 8.1. Due process and equal protection concerns. The inconsistent legal treatment of personality disorders raises constitutional questions. Arbitrary distinctions. Why should antisocial personality disorder disqualify someone from an insanity defense but qualify them for indefinite civil commitment as a sexual predator? The legal system applies different standards to the same diagnosis depending on whether the goal is punishment or prevention. Mens rea and criminal intent. If personality disorders genuinely impair the ability to form criminal intent or appreciate wrongfulness, excluding them from mental health defenses may violate fundamental principles of criminal liability. Some legal scholars argue that personality disorders can and should nullify criminal responsibility when they substantially impair volitional or cognitive capacity. Right to treatment. Individuals involuntarily committed under SVP laws have a theoretical right to treatment, yet the quality and effectiveness of treatment in these facilities is questionable. If commitment is justified by mental disorder, genuine treatment, not mere containment, should be constitutionally required. 8.2. The discrimination paradox. The legal system simultaneously refuses to recognize personality disorders as serious enough to mitigate punishment, uses personality disorders to justify preventive detention, allows personality disorders to be weaponized in civil proceedings, provides inadequate protections against discrimination in employment and other contexts, fails to ensure treatment access comparable to other mental health conditions. This creates a system in which individuals with personality disorders have responsibilities without corresponding rights they are held fully accountable for. Their actions while being denied the accommodations, treatments, and protections afforded to those with other mental health conditions. Even those without personality disorders are affected by the legal system's failure to properly recognize and address these conditions. Workplace productivity and safety. Untreated personality disorders in colleagues or supervisors create toxic work environments, reduce productivity, and increase turnover, costs ultimately borne by employers and coworkers. Community safety. The revolving door of incarceration without treatment increases community crime rates and victimization. Healthcare system strain. Emergency departments and crisis services bear the burden of individuals in acute psychiatric crises who lack access to ongoing treatment. Family court inefficiency. Courts spend enormous resources litigating cases complicated by unrecognized or poorly understood personality disorders. Tax burden. Incarceration costs, emergency healthcare, disability payments, lost tax revenue from unemployment, and legal system expenses create substantial public costs. Social fabric. The stigma and discrimination surrounding personality disorders contribute to broader mental health stigma, reducing help seeking across all diagnoses and perpetuating cycles of untreated mental illness. Several reforms would address the systemic problems created by limited legal recognition of personality disorders. 10.1. Criminal justice reforms. Restore volitional prong to insanity defense. Return to the Model Penal Code's original approach that recognizes both cognitive and volitional impairments. Individualized assessment. Replace categorical exclusions of personality disorders with case-by-case evaluations of functional impairment at the time of the offense. Diversion programs. Expand mental health courts and pretrial diversion programs specifically designed for personality disorders. Treatment-oriented sentencing. When personality disorders are present, prioritize treatment requirements over purely punitive sanctions, with evidence showing this reduces recidivism. 10.2 Civil commitment and healthcare access. Clarify commitment standards. Explicitly include personality disorders in civil commitment statutes when they cause substantial functional impairment and dangerousness. Early intervention programs. Expand evidence-based early intervention for personality disorders, particularly for young people, when treatment is most effective and can prevent decades of dysfunction. Insurance parity enforcement. Require insurance coverage for personality disorder treatments equivalent to coverage for other mental health conditions. Anti-stigma training. Mandate education for healthcare providers about personality disorders to reduce discrimination in medical settings. 10.3 Family law improvements. Trauma-informed courts. Train judges, attorneys, and evaluators in personality disorders, distinguishing active symptoms from recovery, and avoiding diagnostic weaponization. Nuanced assessments. Replace binary fit-unfit determinations with graduated assessments of parenting capacity, needed supports, and appropriate custodial arrangements. Protection for recovery. Ensure that seeking mental health treatment cannot be used against parents in custody proceedings, encouraging rather than discouraging treatment. 10.4 Employment protections. Strengthen ADA coverage. Provide clearer guidance on when personality disorders constitute disabilities, reducing litigation uncertainty. Reasonable accommodations. Develop workplace accommodation frameworks specifically addressing personality disorder symptoms, flexible scheduling, modified work environments, EAP access. Anti-discrimination enforcement. Increase EEOC enforcement against employers who use personality disorder diagnoses to justify adverse employment actions. 10.5 Research and education. Neuroscience and law integration. Bridge the gap between legal concepts and psychological neuroscientific understanding of personality disorders. Public education campaigns. Reduce stigma through evidence-based education about personality disorders, their treatability, and their prevalence. Outcome measurement. Track the costs and benefits of treatment, versus punishment approaches to build the evidence base for policy reform. The legal non-recognition or inconsistent recognition of personality disorders creates a cascade of consequences affecting millions of people, not just those diagnosed with these conditions, but their families, communities, employers, and society at large. The paradox is stark. Personality disorders are simultaneously dismissed as not real mental illness when seeking exculpation or accommodation, yet invoked to justify indefinite detention, custody loss, employment discrimination, and credibility attacks. This legal ambiguity produces substantial human and economic costs, mass incarceration of treatable populations, barriers to healthcare access, workplace discrimination, family court dysfunction, and cycles of violence and victimization. Research demonstrates that personality disorders, particularly borderline personality disorder, respond to treatment, especially early intervention. Yet the legal system's failure to recognize these as serious mental health conditions means resources flow toward punishment and crisis management rather than prevention and recovery. The effects extend beyond individuals with diagnoses. Every taxpayer bears the financial burden of a system that incarcerates rather than treats. Every community faces increased crime from untreated mental illness. Every workplace experiences reduced productivity from stigma and discrimination. And every family court docket is clogged with cases complicated by unrecognized or weaponized psychiatric diagnoses. Legal recognition matters because it determines access to rights, protections, accommodations, and treatment. When personality disorders exist in legal limbo, sometimes recognized, sometimes dismissed, always stigmatized, the result is a justice system that neither rehabilitates effectively nor punishes fairly. Until the legal system develops a coherent, evidence-based, and humane approach to personality disorders, we all pay the price in reduced public safety, wasted resources, perpetuated stigma, and cycles of suffering that could be interrupted through early intervention and appropriate treatment. The question is not whether society can afford to recognize personality disorders legally. It is whether we can afford not to.